From the News Channel 5 Network, this is OpenLine.
Hello, everyone. Welcome to OpenLine. Glad you're with us. Very important topic tonight. We're talking about helping police respond to mental health-related calls. What needs to be done, what is being done. There is a program right now underway where mental health professionals are going out with Metro police officers. It's a program that's been going on for a while. It is called Partners in Care. We're going to be talking about that, how it's going. And again, can it be expanded? You know, where do we go from here? Very happy to have with us two people with the Mental Health Cooperative joining us via Zoom. We have Amanda Brancht and Michael Randolph. Again, both with the Mental Health Cooperative. Michael Randolph is Crisis Supervisor and Overseer of Partners in Care. And Amanda Brancht is Senior Vice President for Public Relations and Community Development. Thank you both for being with us.
Thank you for having us.
Thank you.
So let me start, I guess, Michael, with you and this Partners in Care. Tell us what exactly that is, how it started, and kind of where things stand right now.
Okay, so the origin of where this all comes from goes back to the mayor's, Amanda, you can step in because I didn't come in until a little bit later in this process, but the Police Policy Commission, and they were taking recommendation from the Behavioral and Wellness Council that the mayor has for, behavioral health recommendations for policy. And they kind of recommended, that's kind of leaders in the community in behavioral health, and they recommended exploring co-response models. And then when Chief Drake was named, they called a meeting with me and Amanda to kind of talk about that. And this is before they had created an Office of Policing Strategies. And then they very quickly did. And I got paired with Inspector Imhoff to kind of investigate different co-response models across the country, what's working, what's not working, what could work for our community, and set up a small pilot program to see if we could look at if anything like that would be beneficial for our community. And then we explored a lot of cities. We talked to a lot of different programs, and we actually came to a conclusion that we wanted to model our program after Denver. And they have a variety of programs out in Denver to cover all of the crisis continuum. They have a co-response model. They have our STARS program. And after a few months of work, we started prepping it out, and right now our pilot program is in North Precinct and Hermitage Precinct on the morning shift and the evening shift, so about 6:30 in the morning to about midnight. A counselor shows up every day with those shifts. It goes to roll call. And they get matched up with an officer, but not just any officer. It's an officer who's gone through a 40-hour CIT kind of training that we put on specifically for the program and officers in our program to better teach de-escalation, mental health topics, community resources, and how to really plug people in crisis into those things and de-escalate. And our counselors are matched with those officers trained in that program, and they respond to primarily mental health crises calls. And that car can also go to other police emergencies if there's no mental health crisis going on. But what happens if there is a mental health crisis? The officer makes sure the scene is safe and secure, and the counselor will engage with that person, de-escalate them if necessary, try to connect them with resources, gauge if they're in what kind of mental health crisis they are in, and try to link them to treatment. And the goals of the program are to divert people away from the criminal justice system into the healthcare system, safety for everyone involved, and really streamlining services to the individuals who need it most.
That's great. So a co-response model, that means a counselor is going out with a police officer.
Yes, sir.
And you've modeled this after something in Denver. And so, Amanda, big picture, how desperately was this needed, and how likely is it you think this will be expanded here in Metro?
Sure. Well, I think this is an issue that cities around the U.S. have been looking at, because whether, when you call 911, you're going to get a response. And that response, if you're in a psychiatric crisis, is typically a police officer. And many of, officers, while they receive mental health training, they aren't mental health clinicians. And I think this is something that they said they needed. They wanted to have a crisis intervention team, which is a model that's been around for over 30 years. It started in Memphis. And that's where you train officers to understand how to de-escalate and recognize signs and symptoms of mental illness. And that was the original recommendation from the Policing Policy Commission. But we took it a step further into the co-response because we recognized that that 40-hour training is really good, but it still does not substitute the knowledge and the skills that a clinician may have. And when we talked to Denver and we heard about the evolution of their programs, they started with a traditional crisis intervention team where it's just the police officer identifying, and then they evolved to the co-response. And when we presented that to the rest of our leadership team back at the Mental Health Cooperative, as well as Metro Police Department, that's what we decided is needed in our community. And we really felt strongly that a good partnership between that clinician and that officer would be the most effective tool for their community. I think it's desperately needed because we see far too many people who are ending up in the criminal justice system due in large part to their mental illness that could be diverted into care. In the first 2 quarters of the program, less than 4% of the people we've seen have ended up being arrested. And I think that's a testament to the skills of these teams in getting people diverted appropriately. I think because of the success so far of the program, there is definitely a lot of energy and commitment to expanding it. The goal is to expand at least to 2 more precincts in the next year, and hopefully in the next 2 to 3 years becoming a citywide program.
I'm sure we will get this question tonight, so I'm just going to ask it. Would this have made a difference, do you feel like, in that shooting on the interstate with Landon Eastep that everyone saw and was mortified by? And I'm not making a judgment either way. I'm just saying it was tough to watch. Would this program have made a difference, in your opinion? What do you say about that whole situation? And either of you can take that. Amanda, why don't you take that?
Well, certainly, that's obviously a tragedy and a situation that no one wants to see in our community or anywhere. I think it highlights the importance of having a partnership and strong communication with all your resources, including mental health. It's hard to do an after incident review and say it definitely would have made a difference. I think one of the things that we have to be mindful of is when these co-response teams do arrive on the scene, that we do have to make sure the scene is safe for everybody to be out and about, including the clinician. So that's something that they would have had to take into consideration in a situation like that. So it's hard to say, but I do think it highlights the importance of having not only the partnership and the response, but the ability to get on the phone with a clinician and say, here's some other tactics we might use in these types of situations.
Michael, you oversee this Partners in Care program. And so what this means is there's a counselor that's riding around with a police officer for their entire shift. Is that right? Mm-hmm. And yes, so they're obviously going on calls. Some of those calls have nothing to do with a mental health issue, but they're there for those calls as well. Is that right?
Mm-hmm. Yes, sir.
And how tough is it to staff that? Do we have enough, clinicians that are certified and willing to do this?
Well, I'm lucky in the pilot that I convinced 4 or 5 clinicians other than myself who were currently working full time with our mobile crisis team to follow me and try out this pilot program, and staffing that with very experienced crisis counselors from our mobile crisis team has proved very beneficial. Now, as we look forward, there is a challenge in behavioral health across the country in filling positions with licensed professionals. But this is an exciting program. I've had a lot of emails, a lot of people reaching out to Mental Health Co-op or our counterparts in the police department to say that they are interested in this kind of work. And as we expand, I think we can meet the challenge to really train up good clinicians like this community deserves to answer those kind of crisis calls.
So you are one of the people going out, is that right?
Yes, sir.
And without giving details of a name or something, but identify an individual, can you give us an example of kind of a couple of or 1 or 2 instances where you've come across, what you've come across, I guess, in the time that you've been doing this?
Yeah. such a wide variety of things to talk about. So primarily our car will answer calls that are like welfare checks, where they're checking on people to make sure they're okay. This could be someone who may have sent a text message with some suicidal content. They might be experiencing suicidal thoughts. We see people who disorderly conduct, intoxicated individuals, suicidal individuals, and maybe someone who's trespassing. Some specific stories. A couple of weeks ago, we went on a call where a family member called really concerned about someone because they wrote something on social media where they might be hurting themselves, or they might be wanting to hurt themselves. When we pulled up to the house, there was a suicide note taped on the door, said, you might find me, dead inside. Here's what to do with my dog, et cetera, et cetera. And, the officer immediately got on the radio. We called a bunch of backup, the fire department and ambulance, because they thought that they might have to enter the home, and who knows what we would discover. Fortunately, the individual inside, because we were able to respond quickly, cracked the window open and said, I need you guys to leave the house. I don't want any help, things of that nature. I don't trust police. I was able to talk with her through a window and build some rapport with her, kind of de-escalate the situation, and we got her to unlock the door, come out of the house, and we were able to get her into mental health treatment.
Wow. And when I hear that example, it's tough to think that police had to respond to that with no professional with them. Police, they are our first responders. In many cases, they're the ones that are being called for all of these different things. Family members who they don't know what to do, they call police. And sometimes we have heard that does not end well. And so, Amanda, let me ask you, let's go back a year or 2 years before this program. How concerned, what could family members do? How did that play out?
Yeah, family members, like you said, if you call 911, you're going to get a response, and typically that response is an officer. And sometimes those situations would result in the officer recognizing that the person had an issue, and they would call our regular crisis line or bring them to our crisis treatment center. But sometimes they may not recognize that. And in the case that Michael just described, it would not have been uncommon for a situation with which the police may have had to breach, meaning, enter her home if they thought it was an immediate safety situation. She's distrustful already of the police, and that could have resulted in a physical confrontation. It could have led to, her physically coming after the officer and then being arrested for an assault on an officer. It could, anytime you have to go hands-on, obviously it's traumatic for everybody involved. And it could result in an injury, all because, they may not have recognized the trauma that she was experiencing, or the level of her depression, and been able to gauge that way. And it could have been a triggering event for her. But having the clinician there is an added resource for that officer and for the cause that they're responding to. I think the other, when we first started, the first month of the program, I was getting feedback from Michael and his team about those calls that weren't even originally dispatched as a mental health or a crisis call. And they would get there, and the clinician would pick up on a situation and say, wait a minute, I think, this person has some underlying mental illness, and that's what, can I intervene and start talking to them? And they were able to de-escalate situations that would easily have gone a way that would have been negative for everybody involved. And I think it goes to show that some of the issues that we're responding to really do take a team approach and take a different set of eyes. Officers are trained to do great work, but again, you can't substitute all the skill set of a clinician being there. And they're asked to do so much as first responders. And so I think it's a great thing that we're doing, is giving them the additional resources that many of them have been asking for.
I could see how this could be a little bit of a sticky situation, and maybe I'm wrong, but if there is this situation and there's a clinician that's out there on the scene, and they're picking up on a mental health issue, and there's an officer who's out there and they're very focused on just trying to keep everyone safe, trying to de-escalate an issue, who has the authority to say, okay, why don't we do this or that? In other words, can the clinician step in and say, officer, wait a minute, I think this is a mental health issue, let me go at it? And the officer would say, no, I think this is a safety issue, you've got to stand back. How does that work?
Yeah, I think we saw a lot of these problems coming, and I think it's really a testament to the kind of training we're doing for the officers and the clinicians to kind of cut down on those kind of incidents. Because as far as I am aware of, there hasn't really been many arguments between the clinicians and the officers about those kind of issues. At the end of the day, we have trained our counselors that, hey, the officer, they're an expert on safety. So they make the call on safety. If at any time they say go back to the car or get in the cover, you have to listen to them, get away from the house, things of that nature. They make all the calls on safety. And that's just how we keep our clinicians safe. That's how we keep the people in crisis safe. Because if that officer is worried about the safety of the clinician and not talking to the person who might be a danger to themselves or others, then their attention is split. So our clinician will go out and so that officer can really focus on what needs to be done. As far as clinical decisions or arresting, really one of the pros of our model is that the same clinician generally shows up to their same shift every day. They've gotten to know not just the officers we've trained for the program, but all the officers in that detail. So we have seen an increase of officers we haven't trained picking up on mental health related crises and calling for the clinician and the officers trained to come to their call to kind of check it out, that there may be a mental health component to that. And they're building these relationships and trust. And we actually gave surveys to the officers and the clinicians and about trusting each other's judgment, issues of safety and things of that, et cetera. And they scored very, very high. I don't have the number on top of my head, but it was very high and it was really encouraging. The officers are really good about asking the clinician's opinion when it comes to mental health issues. Our clinicians actually went to 4 days of training by police staff to learn about state law, when officers have discretion not to press charges or not, how to use a police radio, what does some of that jargon mean, what kind of incident decision-making model police officers use. A lot of training focused on situational awareness. Training focused on cutting down on any of those potential disagreements in the field, and so far it's been very successful.
One last question before you go to break, then I'm going to start taking calls if people want to call in. Have things mental health wise gotten more difficult, gotten worse in the pandemic? I mean, what have we seen in the last year? What have we seen, Amanda?
Yeah, we've definitely seen an increase in people who may have been stable pre-pandemic and then fell off that treatment. They were scared to go see their doctor, then they got off medications. We've seen a rise in people who are experiencing setbacks in their treatment. We're also seeing people who've never had mental health encounters before, but because of the social isolation or the loss of a job, loss of social connectedness, are now experiencing mental health symptoms that they've never had before. And we've definitely seen an increase in that. The first few months of COVID, we thought our overall crisis call volume would go down, and it really didn't. And then as the pandemic went on, we saw it continue to go up. At the same time, we have staff who are struggling with the same issues, and also, workforce shortages when it comes to people on the front lines because of COVID exposures. So I think it's definitely impacted our overall system, and it's certainly impacted, we're seeing an impact in the mental health of everybody in our community.
This is easily one of the most important topics in policing today. So I'm glad we're talking about it. We're going to take a break. If you want to call in, question or comment, there is the number, 615-737-PLUS, 615-737-7587. We'll take a break. Be back right after this.